we invite Dr. Vishal Agrawal. He would be talking on eyes on Vabysmo interesting cases in nAMD and DME by Roche.
So I'll be very brief and about the theory part, and jump very shortly to the real world experience and our different interesting cases. The theory part and the pharmacology has been already been well elaborated by Dr. Bhuvan. So as we know, as a retina specialist, day in and day out, the most common diagnosis we make is nAMD and DME, which requires sustained and effective treatments. But both these terms, sustained and effective, is very difficult to achieve in these two conditions, primarily in our country because of the economic constraint. And even if we remove the money out of the equation, we all know that a substantial number of patients do not, respond to anti-VEGF from the first injection itself. And that prompts us to think that there are multifactorial causes for the disease, which includes an inflammatory component. So, and that is where, this whole saga and the story of Ang1 and Ang2 comes in. So, and we have ample evidence now that the angiopoietin pathway maintains vascular stability and homeostasis under physiological conditions. And the Ang2, as Dr. Bhuvan said, is the bad Ang, and it promotes vascular instability by blocking Ang1 and Tie2 signaling pathway. And both Ang2 and VEGF levels are upregulated, although in a different magnitude in different diseases. As you can see in the graph, it's maximum in RVO, and it's quite increased in AMD and diabetic retinopathy. So Vabysmo was launched in India this year, January, and this is the first bispecific molecule to target Ang2 and VEGF using their innovative patented cross-map technology. And it has been seen that both Ang2 and VEGF concentrations return close to baseline at 16 weeks post-dose. And the most important thing is that 8 weeks post-dose, you can see there's almost a separation of 80% of Ang2 concentrations in Vabysmo. So combining, the bispecific inhibition, you can see what we need to achieve. The first slide, the sustained and effective treatment, sustained inhibition of both Ang2 and VEGF-A with the vessel stabilizing effects of dual Ang2 and VEGF-A inhibition leads to prolonged pharmacodynamics. And that is what we need. Every drug is working fine, whether it's aflibercept, brolucizumab, ranibizumab, but what we need is less frequent injections. And these were the trials which led to its approval. Coming to nAMD, it was the TENAYA and Lucerne trial. And the important thing about this trial as compared to the comparator molecule aflibercept was that after the initial loading doses, there was no fixed dose regimen like in aflibercept. There was, Q8 injections till the end of the study. Here, the treatment was, curated as per appearance of new hemorrhages, increase in central subfield thickness, and decrease in BCVA. So these trials were, more close to what you practice in your clinics and what your regimen is in the real world experience. And although, as mentioned by my colleagues and in the previous slides, the vision gain was comparable to aflibercept, but the important thing is that the median number of injections was almost half as compared to aflibercept in the second year, and the reduction in central subfield thickness was also achieved in almost half the number of injections that of aflibercept. And the important thing is that almost 60% achieved of these patients Q16 dosing, and almost 80% achieved Q12 weekly dosing. So now coming to the real world evidence, and why is it important to us? It is important because in RCT data, the patient population is homogeneous, and in our clinics we don't look at the lesion size, the age group, and the scarring level. The patient comes with fluid, decrease in vision, we inject. So it's a more heterogeneous population in the real world scenario. In the routine clinical practice, and there are a number of real world studies already published. So our experience since January is we have injected more than 115 patients. The total number of injections has been more than 200 for Vabysmo. Coming to cases, I'll share a few cases of nAMD and DME which are interesting. This particular gentleman came with a lot of hemorrhage and subfoveal fibrosis and a recent decrease in vision, and this is after multiple anti-VEGF injections. And you can see this OCT 20 weeks post 2 Vabysmo injections, Of course, the visual acuity improvement was modest because of the central scar, but the patient is maintaining the same vision without any recurrence after 20 weeks after 2 Vabysmos. This was a particular aggressive case of RAP, and multiple anti-VEGF injections were given. Fresh bleed was there with fibrosis, and this lady, received 3 loading doses of Vabysmo. The vision improved to 612 parts. She came recently, 15 days back, and you can see the fluid is still not there, and you can see the serial OCTs also. And the patient is maintaining the vision 612 parts without a need of the 4th injection even after 20 weeks. Again, this slide is just to show what had been discussed a couple of minutes back, that this patient was, is a patient of focal CNVM with fluid, and you can see the subretinal fluid. And the patient came, he was on brolucizumab, and after 2 weeks, the patient came to us that you have injected such an expensive drug, but there is no response. But as we were told by the, the company people, that this drug takes a little more time than the other drugs, and the right side OCT is after 4 weeks, and you can see the complete resolution. So it takes a little time, and you have to tell the patient in hand that if you have received aflibercept and brolucizumab, it might take a little time, but the final result will be the same, and perhaps a little more longer acting. So coming to, aggressive cases, this was a patient of massive subretinal bleed. You can see the intraretinal and subretinal fluid with hemorrhage. And at that time, you were, contemplating actually subretinal TPA for this patient. But in January, the drug was, just launched, and we gave the option of a Vabysmo. And this is the amount of resolution you can see on the right side fundus photograph and the OCT below it after 4 weeks of a single injection, and the patient improved to 618 parts. Of course, we gave 3 more injections, and the patient is maintaining 618 without a recurrence of hemorrhage or fluid. This is a one-eyed 80-year-old gentleman. You can see the intraretinal subretinal fluid and the PED. And after 3 Vabysmo injections, this is 16 weeks post 3rd Vabysmo. You can see the serial OCTs. There is a flattening of not a flattening, but there is a reduction of the PED height and a complete resolution of the intraretinal fluid. And the patient is maintaining around 612. This was a 35-year-old software engineer from Gurgaon, and she was, having multiple injections with recurrence after monthly injections of ranibizumab and aflibercept. And she was very frustrated and, depressed at her workplace as well as her personal life. And this one was the first patient which I injected Vabysmo, one of the first patients. And after 2 Vabysmo injections, now she is 20 weeks post the 2nd injection, and the vision is 6/6, and there has been no recurrence. And you can just see the macular anatomy, and it seems that she didn't have any fluid at all at the first place. There was a complete resolution with the restoration of the foveal anatomy. Again, a sub-RP bleed and a lot of fluid, large PED, and multiple anti-VEGFs given elsewhere. There was a fresh bleed. The vision dropped to hand movement. And this is after 3 injections, loading doses of Vabysmo, 16 weeks. The second OCT is after 12 weeks, and they were the third OCT is around 20 weeks post Vabysmo, 3rd, and there was a recurrence after 20 weeks. So the patient maintained the flattening of the PED without any recurrence of the bleed at 16 weeks. But at 20 weeks, we injected the 4th dose of Vabysmo because there was a recurrence. This is a case of subretinal bleed with a PD with multiple anti-VEGFs elsewhere. Again, 20 weeks post Vabysmo after the loading dose. Any of these patients did not require the 4th injection, which I'm mentioning here. The vision improved to 612, still maintaining to 612 parts without the recurrence of the bleed. You can see the serial fundus photographs and the OCTs, and there is no recurrence of the bleed or the fluid in these cases. Again, a thumb-shaped PED, a lot of bleed there. A typical PCV patient, and multiple anti-VEGFs, brolucizumab and ranibizumab given elsewhere. And this is a switch patient, and after 2 doses of post-Vabysmo, this is the 20 weeks follow-up. And here you can see the almost complete flattening of the large PED with the resolution of the bleed. As Dr. Bhuvan mentioned, the thing which I have noticed here with Vabysmo as compared to the other molecules is that the reduction in the bleed, whether it's RVO or whether it's CNVM with bleed, is huge. It's much better than the other drugs. And the patient is maintaining 6/9 after 20 weeks of 2 doses of Vabysmo. This is a secondary CNVM post pattern dystrophy, bilateral symmetrical lesions. The patient, there is a central foveal scar. The patient presented a secondary CNVM with fluid, and this is a complete resolution after 2 doses of Vabysmo. 3rd dose has not been needed till now. Again, these are aggressive cases, and these are all switch patients. A lot of STEM and a PED and a lot of bleed here. You can see in the serial fundus photographs. And this lady required 4 loading doses of Vabysmo. The presenting vision was finger counting 3 meter. You see the last OCT on the right side, the bottom OCT, and you can see the first one on the topmost OCT on the right side. And you won't believe that this is the same OCT of the same patient, because there is a complete resolution of the bleed, there is complete flattening of the PED, and there hasn't been a recurrence for the past 8 weeks till now. Coming to DME, I'll just share only one interesting case, because this is what is interesting. This patient is our own patient, and he has received 13 aflibercepts and 2 Oziodex, and this case exemplifies the case of refractory DME. And finally, we gave him the option of Vabysmo, and 4 weeks post Vabysmo, 4th injection, you can see the serial OCTs on your right side of the slide, and the vision improved to 612. There is no recurrence, and there's a complete dry macula. So just to sum up, almost all the patients, the 100 patients, were equally divided between CNBM or DME. And we now have a study of our own intravitreal faricimab for chorioretinal disorders, evaluating real-world efficacy and safety in India, the INFA study, and we have sent it for publication. And here you can see that the logMAR BCVA, whether the parameter is logMAR BCVA or whether the parameter is central subfield thickness, there has been a significant decrease from the baseline, whether it's in treatment-naive patients or switch patients or refractory patients. So to conclude, there is greater numerical gain in vision after even 1 injection. And majority of the patients, achieved stable, reduced or resolved fluid, including subretinal bleed. And there is rapid improvement in all the parameters, whether it's PED height or whether it's intraretinal fluid or subretinal fluid. Although this, this is evolving data, we have a modest sample size and the follow-up, duration is small, but we'll be more wiser maybe later next year or, early next year when all these patients which we are injecting now come into that the magical Q16 figure which the company claims. And if my patients personally, if I feel, if my DME or nAMD patients, and even if 50% of these patients, require 3 or 4 injections in a year, I think this drug is a game changer. Thank you so much. And I all invite you to Roscon, Udaipur from 8th to 10th November, the annual conference of Rajasthan Ophthalmological Society. Thank you so much.
An excellent presentation, and the house is open for discussion.
Very fascinating pictures I saw, and just a couple of comments. So in a lot of your cases, I saw that the PEDs were really high.
Yes.
So that was what was very interesting about a lot of your cases.
Yeah.
So did you have RP rip in your cases?
Not yet.
Not yet.
Yes.
And more than 200 cases.
More than 225 injections and around 115 patients. So yes. 225 injections of approximately 115 patients. Yes.
So what would be interesting to see is that with faricimab, maybe because it acts in a slower way,
yes,
we are seeing less RP rip than we see with brolucizumab.
Yes.
Because on one hand we had RP rips in the series which was presented here by Dr. Balbir, where and we have seen also RP rips. So maybe it hits very hard.
Yes.
So especially in these cases which have a very high PED or a tall PED.
So rapid drying is not required.
Yes, rapid drying is not indicated. So I
Recommended,
think
yes.
faricimab may be scoring over there.
Yes.
The other point was that I also felt that there was a resistance to injection which decreased once we keep the injection outside. How do you manage that, like with faricimab?
You mean to say the injection procedure?
I mean the viscosity of the
So
drug.
yeah, so the first couple of injections we were really troubled because it's really hard to push because it's very viscous. So now what they have told us and what we follow now is that 30 minutes before we remove it from the refrigerator, the injection, and now it's still a little more pushier than the other drugs, but still makes life easy rather than if you just freshly take it out from the refrigerator, then it's really viscous.
Right.
And the second thing, what you mentioned is every patient who you are switching from brolucizumab and aflibercept, you have to mention that this is a slow-acting drug. Do not come running after me after 10 days because they'll eat your head. It's an expensive injection. They'll say that what was the difference? It's not acting even after 2 weeks. So you have to be a little patient at 4 weeks.
Also, did you see any, IOI or vitritis after
Nothing.
any of the cases?
No.
Okay.
No AC cells, nothing till now.
No vitreous cells.
No vitreous cells also.
Because we look for vitreous cells, and we did have a couple of cases. My series is much smaller than yours, but it's after that that I became more cautious. Although none of them turned out to be serious, but they were vitreous cells, and
But what was the follow-up time? When did you see those vitreous
so
cells?
they came up maybe about 2 to 3 weeks following the injection.
So you called them for the regular follow-up, or they complained a decrease in vision?
No. So yeah, that was interesting that in one of the patients, the patient reported with floaters. Okay. So that patient did have a history of Pagenex injection in the past.
Okay.
So in fact, I put this up in one of the online meetings where you were also there, and I think we had the faculty from abroad who said that if it's a Pagenex injected patient, they are primed for IOI.
That could have been a compounding effect with
yes.
the
But the thing is that I had a patient who was Pagenex naive, who had vitreous cells. Of course, it resolved. But again, this just goes to show that we have to be a little careful with these high molality drugs, and the chance of IOI, although not serious, is always there, and we have to be on the lookout for that.
So what I'm trying to tell you is that all these drugs are very good, and they have a drying effect, very good. And most of these drugs are acting till 12 weeks, whether it's Vabysmo or aflibercept. But this is the drug which I have felt can be extended till 16 weeks in almost 50% of the patients. And the second point is what I showed you, intentionally I kept those cases where there was a lot of subretinal and sub-RP bleed. And this drug is especially effective in resolving that bleed. The mechanism I don't know, but it's really effective in resolving and drying up that bleed.
It was nice presentation, and even I do agree. Whatever I have used Vabysmo, it's like slow acting drug. But if we look at the IOIs or any reactions of vitreous cells, I hope every one of us might have experienced with one or the other drug, one or the other time. So it's not compulsorily that it's coming with particular drug, might be a patient's perspective. From patient's perspective, the systemic diseases and all, they will also play a role for that.
Also, does anyone inject dexamethasone like Dr. Balbiro was suggesting with brolucizumab? Are you guys injecting dexamethasone?
The chronic CNVMs with the scar and with refractory fluid, I do inject.
No, is it for IOI? Because in the West, some people were, kind of co-treating with steroids preventively to prevent IOI. Any of you?
You mean prophylactic dexamethasone along with the injection?
Yes, or topical steroids for that matter. Anybody uses topical steroids?
Steroid, but I do at least give, sometimes I do give Tovadiem with Pagenex, maybe. Dex or something.
Yeah, even
Drop.
I use
Topical dexamethasone.
Topical, slow, very short.
But
tapering
then
course.
again, the question is, I'm not criticizing any drug. Every drug is very effective. When you are in a private practice and not in an institutional practice, why take a chance of a drug which has a significant amount of IOI? Whether it's not proved in the Indian population, okay. But most of the reports of adverse effect and risk mitigating algorithms are on brolucizumab. So are you willing to take that chance when the price range is the same, the effectiveness is the same? So that is a practical question we have to answer.
I don't think that Pagenex is on the same platform as Eylea and Vabysmo.
Yes.
It's not. So I think it's, and probably I don't know whether it'll achieve that ever.
Yes.
So there is no doubt that we all agree that there is some issues with that. So, but then it is a drug, and it is a drug which does work at some times. It does. So, and with Vabysmo coming in, maybe things will change.
I think it
Can
all
I
works.
ask that what are the clinical characteristics or the OCT characteristics that guide you to what anti-VEGF to choose from the entire list of drugs available?
So, madam,
What
that
in
is
the
very
treatment
difficult
naive
to,
patients?
very difficult to say. So, there are two categories of patients. One is who cannot afford, who do not have medical insurance, and they are mostly injected by all of us, by biosimilars, maybe by Avastin. These drugs also work wonderfully. What we are talking about here is who have a medical. Most of the 90% of my patients had medical insurance. They cannot afford 3 or 4 lakh rupees treatment. Okay. So if they pay by cash, that's very difficult. So all are covered by medical insurance. Then you can compare aflibercept, brolucizumab, or faricimab. So these three drugs are on the expensive sides, and they all are effective. So you cannot compare all the patients, because majority of the patients are still biosimilars for everybody's practice.
Yeah, but I just wanted to add one thing for what Dr. Saurabh had. I don't think giving Tovadiem or giving a DEXA implant is of any use with Pagenex, because every patient will not develop it. No. I think a better practice is that you follow up the patient at 2 weeks, 10 to 14 weeks when there is a risk, and if develops, then probably we should act by these steroids.
And do not repeat it before 1 month. Before 6 weeks. Before
I
6
think
weeks.
before Pagenax is a drug which mostly we follow PRN regime with the first drug.
Even I do agree because we don't have so many IOIs. So that's a good point that we should follow up the patient very frequently.
So repeatability after 6 weeks, I would say that, you know, there were those 2 trials which were, you know, kind of discontinued because in that they were trying to inject more frequently. But
Merlin.
yeah, Merlin. I would say 2 to 3 months because I had a case of occlusive vasculitis, and that the difference between the doses was 3 months.
Still it had.
Still after the 2 weeks after the 3rd dose.
Okay, can we go next?
I think it's more safer
No,
to be
but the fortunate thing was that the
PRN, I think
macula was not involved.
I follow
and-
PRN.
Yeah.
I mean, you
So
know,
fortunately the macula was not involved, but yes, you know, I am very, very careful about, you know, and in that
Yeah.
patient, the patient was it demanded for that, you know, injection, and the Eylea injection prior to that was giving rise to fluid every 4 to 6 weeks. So I didn't have a choice. You know, there was nothing else which I could offer to the patient.
Yeah. I think wonderful presentation.